Hello everyone. So before starting this topic, I have already talked about the classification of diuretics, in which I have discussed about various drugs which have come under the different classification. This we have discussed earlier: high efficacy, moderate efficacy and low efficacy diuretics, and how these drugs are classified. Today we'll discuss about each and every drug, their mechanism of action and their pharmacokinetics and its important key points to remember for the exam. So first is loop diuretics. Before starting further, we'll discuss about various channels present over the nephron and how and in which area the diuretics act. So first is PCT. PCT has NaHCO3. These channels are present and it is inhibited mainly by drugs like carbonic anhydrase inhibitors. Then we have thick ascending loop of Henle, which has NaK2Cl, and it is inhibited by mainly loop diuretics. Then we have DCT. It has NaCl, which is inhibited by drugs like thiazides. And last is NaK channels in collecting tubule, which is inhibited by potassium-sparing diuretics. So loop diuretics, it act in this thick ascending limb of loop of Henle, and it causes excretion of sodium, potassium, magnesium, hydrogen ions, but it increases reabsorption of glucose, uric acid and lipid. For calcium, you can also remember loop loses calcium, so it causes excretion of calcium. Then T half. So the T half of most of the drugs of loop diuretics is 1 hour. Exception is torsemide. Torsemide has T half of 3.5 hours. Next is bumetanide. It is the most potent drug in loop diuretics class. Ethacrenic acid is the least. Action of furosemide lasts for 6 hours. That's why it is known as Lasix, that is last 6 hours. If we'll talk about T half of furosemide, it is 2 hours, which is increased to 10 hours in cases of renal failure. Now we'll talk about uses. So uses of loop diuretics are in cases of edema, CCF, nephrotic syndrome, cirrhosis of liver, hypertension, acute renal failure and drug poisoning such as barbiturates, because barbiturate is an acidic drug and loop diuretics make the urine alkaline and will cause excretion. This sums up loop diuretics. Now thiazide diuretics. Thiazide diuretics acts on NaCl's import channels in DCT, which is present over here. Its oral absorption is good and T half is 1 hour to 47 hour. 1 hour T half is for drug chlorothiazide, which is the most potent. Yesterday we have discussed thiazide has chlorothiazide and thiazide like drug have chlorothalidone drug. So chlorothalidone has the longest acting property due to the T half. It has the longest T half. The indapamide and metolazone is used when GFR is less than 20 ml per minute. That is, it is used in cases of renal failure. What thiazide do? It causes excretion of sodium, potassium, magnesium, hydrogen ion, but its role is same as loop diuretics. It increases glucose, uric acid and lipid. Along with that, calcium will also be increased in blood in cases of thiazide, which is not similar to loop diuretic action. Only calcium will have the different role in both. But increase in calcium will cause renal stone, but in thiazide it does not cause renal stone because it will not accumulate in kidney and hence renal stones will not be caused. That's why we can give thiazide in cases of diseases like renal stone. It is used in hypertension, CCF, cirrhosis of liver, resistant edema, in which thiazide can be given along with loop diuretics. Thiazide is a drug of choice for diabetes insipidus and it also prevents renal stone, as we have discussed earlier. Third is potassium-sparing diuretics. Potassium-sparing diuretics has two mechanisms. It first combines with mineralocorticosteroid receptor and inhibit the combination of aldosterone 2 receptor. And it has another role, like it inhibits the ENaC channel, that is epithelium sodium channel. We have earlier discussed that potassium has two roles. It will inhibit the ENaC channel and mineralocorticoid receptor antagonist. So here it has two actions. First, it combines with mineralocorticoid receptor and inhibit the combination of aldosterone to receptor, which will decreases the absorption of sodium and calcium and increases the absorption of potassium, calcium, magnesium and hydrogen ion. Along with that, hyperuricemia will also be seen in cases of potassium-sparing diuretics on chronic use. It is used in cases of essential hypertension, heart failure, hirsutism and polycystic ovary. In cases of edema, it is also used, such as Crohn's disease, which is primary hyperaldosteronism, and in resistant edema due to secondary hyperaldosteronism. Its side effects are gynecomastia, reduced libido, impotency in males. Triamterone and amilorides are the other drugs which inhibit ENaC channel in late DCT and CT. ENaC is epithelium sodium channel, also known as sodium channel non-neuronal 1, that is SCNN1. It inhibits the reabsorption of sodium. So both of them have similar action, that is they inhibit reabsorption of calcium but via different route. It inhibits the mineralocorticoid receptor and it inhibits ENaC channel. The other uses of this potassium-sparing diuretics are cystic fibrosis, in which amiloride is the drug of choice; lithium-induced nephrogenic diabetes insipidus, in which amiloride is the drug of choice, but in cases of diabetes inhibitors, thiazide is the drug of choice. In cases of Liddle syndrome, it is also used, and also used in cases of pseudoaldosteronism. Next, we have carbonic anhydrase inhibitors. So how this work? Carbonic anhydrase inhibitors mainly act in PCT, where there is lumen through which urine passes the cell and blood. So in lumen and cell, there is a channel which will exchange sodium and hydrogen. So what does it do? Normally, hydrogen will be excreted out in the lumen and it combines with HCO3 and form H2CO3, which in the presence of carbonic anhydrase forms H2O plus CO2. This H2O plus CO2 will enter the cell and under the presence of carbonic anhydrase form H2CO3, which will be divided into H plus and HCO3 minus. If we will inhibit these carbonic anhydrase, it will cause decrease in HCO3. That is, HCO3 will be decreased and it will cause decrease in H plus also, and hence less Na will be exchanged. That is, this will not work and increase sodium in lumen, and water will reabsorb and cause diuresis. So this is how it will work. It will cause excretion of all of these. Mainly potassium is majorly excreted. Actions: it increases seizures threshold, that's why it is used in cases of epilepsy. It decreases CSF production. It decreases the formation of aqueous humor, hence we can use this in cases of glaucoma. It decreases amount of CO2 in expired air and increases level of CO2 in peripheral tissue by inhibiting carbonic anhydrase enzyme in RBC. It is used in glaucoma, as we have discussed earlier. Acute mountain sickness, we can use this drug in cases of mountain sickness. To make the urine alkaline, we can also use this drug, and also in cases of epilepsy because it increases the seizure threshold. Next is osmotic diuretics. Osmotic diuretics increases osmotic pressure. It is almost inert in pharmacologically, but act on descending loop of Henle and PCT. Osmotic diuretics will excrete all of these. If we'll talk about IV osmotic diuretics used is mannitol, and oral it is used is glycerin and isosorbide. It is used in cases of when there is increased intraocular pressure, so it decreases intraocular pressure. It decreases intracranial pressure, used in acute renal failure. It is also used in dialysis induced hypotension and remove toxin from GIT. So here are the key points. All diuretics acts at luminal site and aldosterone antagonist act on interstitial site.